Yeah, my name is Claus Koehnlein. I just want to talk how I just want to tell you how I got into this issue. I'm an internal medical doctor who worked in the oncological department of the university in Kiel. And when I worked there, we had the first AIDS patients. Well, they were. I stood with a colleague in front of a patient who was suffering from lymphoma. He was suffering from Burkitt lymphoma, and we had a lot of lymphomas at that time in the oncological department. And the next day, I was told this guy with a lymphoma has got AIDS. And I asked, how comes he got AIDS now? Yesterday he was suffering from lymphoma. And then they told me, well, he's got a positive HIV test. That was in 1989 or 98 or something like that. It was in the end of the 80s. We are all a little bit behind the States. And well, I told to my colleague, well, for me, that's not a new disease. It's just the epidemic of a new test, because we have this disease all the time here. We have histoplasmosis, we have lymphoma, we have other sort of cancers. And why is this lymphoma all of a sudden an AIDS case? And I had another discussion with a friend of mine, with a colleague of mine, and he told me, show me an AIDS patient without the positive, without HIV. And I said to him, well, that's a problem. In your opinion, that's not an AIDS patient if he has no HIV. But I can show you a lot of patients here at our ward who has the clinical sign of AIDS. Look at the lymphoma patients who are tested negative. Look at histoplasmosis here on the other side, who is, if she was HIV positive, would be an AIDS patient. That's what we all know. What is AIDS? AIDS is grit. It is still grit. If you look at the epidemiology, we still have the AIDS problem in the gay population. And we had some documents in earlier times. You see that there was almost 100% correlation with poppers. You see that the AIDS crisis had a time when poppers were widely available and were sold in a very high amount. And the problem was that the virus hypothesis was adopted by a press conference and not by a scientific paper. Then they were quick to invent this epidemic. These pictures are from from the mainstream press, Der Spiegel and Bild der Wissenschaften. We did extrapolate it, and we found out that in 1993, whole Germany would die on AIDS, or would get AIDS and die 2 years later. That were the predictions at that time, and we know that hasn't happened. That's the problem which most of the doctors have, the correlation argument. You get a 100% correlation. That was the talk which I had with my colleague, that I couldn't show him an AIDS patient without an HIV test. And with that, you can really invent epidemics. You just need a new antibody test. For example, now with the swine flu, you don't even need a new disease. You just need a new antibody test and spread it to the population. And then they say, well, yet now you've got a new flu, and it's not anymore the old flu. And I made some skeptical thoughts about creating epidemics. You can take a disease whose cause is unknown, like overweight, for instance, because if you ask the patient it's possible that it comes from too much eating. He always say, no, that's impossible. If you knew what I eat, it's just like that. So you could say, well, maybe it's an infectious issue, and if you're going to isolate from the fat tissue a virus, make an antibody test against it, and distribute it to the population, then you will find some people who react positive to this antibody and are still thin. Then you need the incubation period. Can say, yeah, you are thin now, but wait for 10 years, then you will be fat. And to prevent that, we'll give you antiviral drugs today. So that keeps you thin, indeed. Yeah, what happened to the AIDS crisis? The problem was that the licensing study was terminated too early. That was the reason for the big disaster in the 80s. You know this study, ACT, 1,500 milligrams ACT were studied with a placebo group, and after 4 months, the verum group seemed to do better than the placebo group. But if you looked at the side effects, they showed already the imminent bone marrow suppression. But they closed the study because the pressure of the patients was very high, and also the pharmaceutical industry was interested in getting a new drug. So after 4 months, the placebo control was closed. And after that time, the mortality rose tremendously. The next, please.
Is that the official study?
Yeah, that was the official study. And the mortality rose tremendously, but we had no more control. That was the time when I had patients who heard about my critical view of AIDS, came, and those were critical about the ACT problem. And these were the survivors at that time. They were all recommended ACT, but they all declined ACT, and that saved their life at that time. There was a very similar problem in another study, but this was very obvious that there was something wrong. They investigated hepatitis B here, and after a few months, the patients got really sick. They had severe mitochondrial damage, which led to lactic acidosis and liver failure, and that was not usual in hepatitis B patients. That's why the doctors noticed that there was something seriously wrong. In the case of AIDS and ACT, doctors thought, well, these poor guys have to die. They die in spite of ACT. That's what the doctors at that time thought. They didn't get it, or they got it very, very late, that indeed ACT was the cause of the wasting away of the patients. That's this devil's circle. You have the virus hypothesis, you give antiviral therapy, and you get a slowly progressive immune suppression, and that indeed seems to prove the virus hypothesis. So that was the problem of the doctors in that time, because we had no placebo control. It became then obvious in the Concord results that more ACT kills more people. There was something like a placebo group. You had the IM group and the deferred group. That means that there were people who got ACT immediately and some got it later. And you see that those who got it immediately had the higher death rate. And this was already done with 1,000 milligrams ACT. It wasn't the initial high doses. And still you see that those who got more ACT had the higher death rate. It should have been the death of ACT, but somehow it survived in a still smaller dosage. Then Science wrote that there might be a problem with ACT, that some people can't take it. ACT can keep some AIDS patients alive. and even reverse their dementias, but it's so toxic that the majority of patients may not be able to take it. The problem is once your bone marrow goes down, you have lost. If you take them off the drugs, then you are in a deep immunosuppressive state, and any microbe can kill you. That was AIDS by prescription, as we heard already today from John Lauritsen. That was the time. So one good thing is that the therapy came down, that the dosage was reduced. And this is the study which closed the discussion, I would say. It closed the discussion with us and the orthodoxy, because here you see the mortality of the hemophiliacs. That was a study that was done by Darby et al. And was published in Nature very widely. And you see that only the HIV-positive hemophiliacs are going to die. Peter, maybe you remember that that was the slide they showed in Kiel when we had the talk there as proof that HIV causes AIDS, that ultimate proof that HIV causes AIDS. What you can see here is that ACT caused the death of the patient, because it's timely exactly when he was administered in 1987, the mortality rose tremendously. And also what most doctors don't know about hemophiliacs is the problem that they had before factor VIII was available, a very poor life expectancy. And that became much better while getting this factor VIII. But at that time, they should be infected with HIV. So they should have died already in the late 70s if HIV was the cause. But that didn't happen. Instead, their median lifespan doubled at that time. And they started to die exactly at the time ACT was administered. That's the problem with the HIV hypothesis. If you are negative, you get the normal treatment. For TB, you get the tuberculosis treatment, pneumonia, antibiotics, and histoplasmosis. You get antifungal. By CMV, you have a problem because you need antiviral, maybe. Septicemia, you can get antibiotics. And on the other hand, there you only get it for a short time until your symptoms are over, and then you stop the treatment. But here you get lifelong antiviral treatment. That's why the prognosis is much worse on that side. That we heard today enough. AIDS in Africa, an epidemic of HIV testing, false positive results in patients with leprosy and TB. And next, please. That's the situation. The bad situation that now healthy children get toxic drugs in the beginning of their lives. There are some thoughts I had when I saw this picture, because in Africa the main problem of AIDS is tuberculosis. And tuberculosis is of course transmissible to the child. That's probably the reason why the orthodoxy thinks that it's better to treat children, because they have sometimes maybe an effect that children don't get TB if they get these chemicals. But it would be much better if they would take the antibiotic treatment and not this cytotoxic treatment. But also the cytotoxic treatment can kill TB, but on a very high price, that you just at the same time damage the immune system. But that's, I always try to understand a bit the orthodoxy, because I'm myself an Orthodox doctor. So that's why I think they think also that AIDS is transmissible, because TB is transmissible, and TB in Africa is the AIDS-defining disease. That's why they are so sure that they are right. Yeah, we had that already, the hemophiliacs. infection around that time, and the lifespan doubles in 1985, and a sharp increase of mortality was exactly at the year when ACT, or the year after ACT. Yeah, that's the other hypothesis, that drugs and foreign proteins and ACT causes AIDS. The foreign proteins are in the factor VIII preparations. That means hemophiliacs indeed have a immunosuppressive risk, because in order to survive, they are dependent on foreign proteins. So they have more opportunistic problems than other people, but they still have almost a normal lifespan now. We used foreign proteins in treating autoimmune diseases, so it has indeed immunosuppressive reaction. Yeah, an old guard urges virologists to go back to basics. That was in science. Thanks to techniques like PCR and sequencing, diagnostic labs can perform high sensitivity tests of a battery of viruses in a matter of hours. But by comparing viral genomes, researchers can even construct complete phylogenetic trees. Although this is terrific, a string of DNA letters in a data bank tells little or nothing about how a virus multiplies or how it makes people sick. And nowadays, we get more and more new viruses. There is a similar epidemic, like the AIDS epidemic, that is the hepatitis C epidemic. I don't know whether some of you know the origin of that. We have A, we have B, and we had a post-transfusion hepatitis, where researchers thought there could be another infectious agent. And they made they tried to find out. They took blood from a patient with a post-transfusion hepatitis and put it into chimpanzees, and had one control in another room. That was the control. So they had 5 chimpanzees injected with blood, and the control was not injected with blood. It was just kept in another room. And well, they found nothing in these infected chimpanzees, but they found a little string of RNA, and they built an antibody against it. That was the hepatitis C antibody, and this antibody now they spread to the population, and quite a lot of people react positive to this antibody, HCV, and they are told now, well, you have a problem. You have it not now, but you have it probably in the next 30 years. And that you don't get in 30 years in liver problems. It should be good for you to take antivirals today already. That's what a colleague of mine found in hepatitis C negative individuals. That was a colleague in Lübeck, Denin. He found this virus-specific DNA sequence in human DNA in healthy HCV negative individuals. That means it's possible that these sequences are in the human genome. And if you look at the clinical outcomes after a hepatitis C infection, then you find that there is, in fact, nothing. They come out from 62,000 women. They found 7 cirrhosis. That it's even less than you would expect in the normal population. And confronted with this, they told me, well, maybe they drank less alcohol because they knew they were infected. Also, if you talk about hepatitis C, they are quick to point out that there are, of course, cofactors like alcohol and drugs, which could make things worse. But if you need a cofactor, you can say, well, the factor is enough. Alcohol could be the factor, and the drugs could be the factor as well. You don't need a virus to get a liver cirrhosis and a liver cell carcinoma. That's the same. Shows that hepatitis C is not a serious problem. This was done by Saif et al. They looked on frozen seras, They had a 45 years follow-up in the army, and they found out that mortality and morbidity in liver problems are almost the same in HCV-positive and HCV-negative people. They had low liver-related morbidity and mortality rates. But still, if you ask the doctor now, today, you get to hear, we have to measure your virus load, and if it's high, we have to treat you. And it's a big problem for surgeons, for instance, because they have to be treated, otherwise they are not allowed to operate anymore. That's the trick with the incubation period. The problem is that if you are tested positive, in most cases you have no serious health problems. That's why you have invent an incubation period. HIV 15 years, HCV 30 years, BSE almost 55 years, and HPV 55. And then we are here with life is a sexually transmitted disease which ends deadly after an incubation period of 77 years. Yeah, I think we have to mention Charlton Gajusek because he was the one who invented this chapter of slow viruses. And maybe you remember all the trials he did in the Papua New Guinea when he got this dementia kuru, and he thought it was transmissible via cannibalism. To prove that, he fed some chimpanzees with a supposedly infected brain, but that didn't irritate them. And then he injected them the brain, but still that didn't irritate them. And then he made a bizarre experiment. He drew small holes in the head of the animals and put the supposedly infected brain in. And all of a sudden, the animals got sick. And at that moment, he thought he had a transmissible disease. But it was, in fact, an experimental allergic reaction to these foreign proteins, which make the ape sick. But this kuru should have a consequence. You all remember the BSE panic. I just want to show that, the inconsistencies of epidemiology with BSE and new variant of Creutzfeldt-Jakob disease. I found these two things, one in the Lancet and one, these two pictures, one in the Lancet and one in Nature. And both, one showed the incidence of non-variant of Creutzfeldt-Jakob disease, the other one showed the incidence of BSE. And you see there's directly a non-correlation. That would really disprove that there was a correlation, but obviously nobody saw it, and I sent it to a journal and asked them just to show that without any words. But they wouldn't like to show the picture there, so I had to write a letter, and they published it. But that would have been much nicer, I think, because you see it with one glance. So, but back to AIDS. Why was this medical disaster, the ACT problem, not visible in time? I would just try to explain you that why the doctors didn't notice it. The doctor had no clinical experience with with AIDS patients in Germany, at least in our clinic. We just heard from America that there have been some AIDS patients who are really who were dying in their 30s, and that's why they didn't know what was going on. In treating them with ACT, the patients behaved as expected. They wasted away. The symptoms of progressive AIDS intoxication were almost indistinguishable from progressing AIDS at that time. The next, please. And this is, I think, the central question. Why is the medical establishment so sure that they are right? They are so sure that they don't even have to come to the spectator, and that they don't have to discuss this problem. You have, when you treat AIDS patient, you have two situations. The patient is healthy, then his viral load is going measured and the CDC are measured, or the patient is sick and he gets antivirals and the CD4 cells goes up and the viral load goes down. And the patient is, in most cases, clinically improving. So they ask, where's the question? The CD4, the surrogate marker, behave as expected, and the patient is clinically improving. So they really ask you, where is the question? The explanation is that the viral load goes down if you give a cytotoxic treatment. It's an unspecific reaction. And today, you can find any microbe with PCR. The problem is, if you find CMV and herpes and HIV and HCV nowadays, you get a treatment for every microbe. I had a patient seen in Italy who was treated for lymphoma. He got also against herpes, which is another nucleoside analog, and he got treatment against CMV. He got treatment against HCV. It was an unbelievable amount of chemical insults, and it didn't last very long. He was dead within 2 months. But he was actually suffering from a lymphoma. That's another question. Is a low CD4 count exclusively seen in an HIV infection? The problem is it's only measured in HIV infection. Nobody measures it if you're not HIV infected. That's why the correlation is quite good. But if you measure it in HIV negative patients, you sometimes find the same CD4 problems which you find in HIV positive patients. You see it, for instance, in CMV infection, and you see it in sarcoidosis, for instance, is another disease which does exactly what HIV is said to do. It has a low CD4 count, a high CD8, and you have infiltrates in the lung, and if you give a cytotoxic treatment, people improve. So there are maybe quite a lot of AIDS diseases, sarcoidosis, and that's why they improve when you give a cytotoxic treatment. There are some diseases which react good to the cytotoxic treatment. You know, autoimmune diseases we treat with cortisone, not with very much success, but we do it, and the patients get better. Lupus, Wegener's disease, all the chronic bowel disease get better if you give cytotoxic treatment. Polymyalgia gets better. Mycobacterium infections or sarcoidosis gets better. Lymphomas, protozoan disease, a number of parasites induce strong suppressor mechanism, including T suppressor cells, which eliminate the host's effective immune responses. So some protozoan disease itself make immune suppression, which is a big problem in Africa probably. And also those protozoan disease you can hit with antiviral drugs, of course, but it would be much better to treat these protozoan disease with proven drugs, which selectively kill the protozoas and not so much of the cells of the host. Also, malaria and leishmaniasis will have problems with antiviral drugs, but still it's much better to treat malaria with proven drugs and toxoplasmosis as well. But I have cases with toxoplasmosis in gay men. They improved under antiviral drugs, and the toxoplasmosis went. So for the orthodox doctors, that's proof that antiviral therapy helps. But you cannot get toxoplasmosis therapy as a single therapy if you're HIV positive nowadays. You always get antiviral drugs. The shorter history of antiviral treatment, the only good thing is that it's getting less and less. That's why people are living longer and longer. And since 2000, we do a lot of treatment interruptions. Patients himself do a lot of treatment interruptions. And that's why the survival time gets better and better. Next. Yeah, that's what I told a colleague of mine. Why don't we have a placebo control? But the medical establishment claims there are abundant placebo controls. But that's not a real placebo control. It's one drug regime is tested against another one, plus placebo, but not compared to nothing, because this would be official unethical. And when I told it to a friend, he whispered to his neighbor, he means against nothing. I said, yes, I mean against nothing, because he told me, oh, there are so many placebo-controlled trials. Next, please. Yeah, I would close my talk with Gallo's claim, remove HIV and there is no more AIDS. Remove HIV from the blood supply and there is no more AIDS from blood transfusion. And the last proof is the incredible increase of survival due to antiviral therapy. I would say, stop testing for HIV and there is no more AIDS. The HIV test is highly diagnostic, misleading. The average survival time after blood transfusion is still 2 years, irrespective of HIV, because the underlying disease is severe in most cases. And it's, of course, easy to claim an incredible increase of survival after having killed or overtreated a whole generation of AIDS patients. Thank you very much for your attention.